Welcome, everyone. Today, we are going to tackle something that's absolutely key for your phlebotomy certification, and honestly, for your everyday practice. We're talking about how to troubleshoot a difficult draw.
So let's just jump right into a scenario that every single phlebotomist, I mean everyone, is going to face. It's that moment. You know, the one that really tests your confidence. You've made the perfect stick, you pop in the tube, and absolutely nothing happens. What do?
Okay, first rule, don't panic. The absolute key here is to have a calm, systematic approach, and that's exactly what we're going to build for you today, a kind of mental framework. You know, this stuff isn't just about passing your exam, it's about patient safety and really becoming a pro.
So here's what we've got on the docket. First, we'll look at what a perfect draw looks like. Then, we'll jump into troubleshooting when there's no blood flow and what to do with slow flow or hematomas. After that, we'll cover the really important red flags when you have to stop immediately. And finally, we'll talk about prevention and documentation. Let's get into it.
Right, so before we can start fixing problems, we need to know what we're aiming for, right? Let's take a quick look at the gold standard, because understanding a perfect draw is the foundation for, well, everything else.
So these are the signs that you've absolutely nailed it. The bevel is up and right in the center of the vein. Your angle is just right, between 15 and 30 degrees. Your hand is totally steady, the holder isn't moving an inch. The tube fills up nice and smooth, and this is a big one. Your patient isn't feeling any sharp, shooting, or electric pain. This is our goal, every single time.
Okay, let's get into the nitty-gritty. This is probably the most common and definitely the most frustrating problem you'll face. You've put the tube in and no blood. So what's going on here? And more importantly, what's your next move?
So you might hear this little pfft sound, like a tiny hiss, or maybe you see a flash of red right there in the hub, but then it's gone just as fast as it appeared. This right here is the classic textbook sign of vacuum loss. The suction from the tube isn't pulling blood from the vein, it's just escaping out into the air.
And what's great is that the fix is usually pretty simple. The cause? The bevel of your needle is probably just partially outside the skin, maybe your angle was a little too steep. You don't have to pull out and start over. All you do is discard that first tube, gently advance the needle just a tiny bit so the bevel is fully under the skin, and then, this is key, engage a new tube. Now, this is a huge one for your exam, so listen up. The core principle is this: always fix the simple stuff first. Before you even think about moving that needle around in the patient's arm, you check two things: reseat the depth and replace the tube. Always drop the suction, meaning take the tube off, before you make any of those tiny adjustments.
Okay, so this next one can feel a lot like the last one, but the cause is totally different. You get no fill, maybe a tiny flicker of blood, and then nothing. But this time, there's no hiss. That tells you the vacuum is fine. The problem isn't the tube, it's the depth of your needle. It's just not in that sweet spot.
So what do? Well, it depends. If you're short of the vein, you just advance the needle a tiny bit along that same angle. If you've gone all the way through the vein, a through and through, you need to withdraw slowly and carefully until you see that flashback. The key word here is small adjustments along that original path. No digging, no fishing around side to side, ever.
All right, let's look at a couple more no-flow scenarios. These can happen even when you think your depth is perfect. The issue here isn't you, exactly. It's the vein itself reacting to the needle and the vacuum.
Okay, are you starting to see the pattern here? If the vein collapses, meaning the walls just draw together from the vacuum, you might need to adjust the tourniquet, pause, and try a smaller tube with less suction. If the bevel is just pressed up against the wall, you do something similar. But in both cases, what's the first step? You got it. Remove the tube. You always release that vacuum before you adjust the needle. It's all about preventing trauma to that vein. Okay, moving on. Let's talk about when you are getting blood, but it's just slow. It's sluggish, not that nice, smooth flow we want. You really got to pay attention here, because this is often the very first warning sign that a hematoma is starting to form. So if you're getting the super slow fill and you see any tissue swelling, that likely means the bevel is only barely in the vein and it's leaking. You can try a tiny advance, but if that swelling continues, you stop, period. Same if you've gone too deep and the bevel is partially through the bottom wall. Any sign of a hematoma forming, any swelling at all, is your non-negotiable sign to abort the draw. You risk injuring the patient and you're going to get a bad sample anyway.
This is so important. So many of these little mistakes, like pushing the needle a bit deeper when you change tubes, happen just because the holder isn't stable. A shaky hand is what causes that bevel to shift. So what's the pro move? You brace your hand against the patient's arm. That creates a super stable platform and keeps everything locked in place.
All right, now we need to talk about the absolute most important part of this whole thing. These are the red flags, the situations where there are no second chances, no adjustments. Your only move is to stop immediately, no questions asked. Patient safety is always, always number one.
Okay, 2 critical ones you need to know cold for your exam and for real life. First, nerve contact. If your patient says they feel a sharp, radiating pain, like an electric shock shooting down their arm, that's a nerve. You withdraw immediately, apply pressure, and you document it. Second, an arterial puncture. You'll see bright red blood and it'll probably be pulsing. The tube might fill super fast. Again, withdraw immediately and apply firm, direct pressure for a good long while.
So let's just list the things you should never ever do. No lateral fishing or sweeping movements. No aggressive, deep redirections. Don't probe around blindly if you're not sure where you are. And as we said, never continue a draw if a hematoma is forming or if the patient reports that sharp, radiating pain. Look, this isn't just bad technique, it's dangerous. It's how you cause real injury. And frankly, it's how you fail your exam. The best advice? If you're lost, just get out.
So, after all that talk about fixing things, how do we just not have these problems to begin with? This last part is all about shifting your mindset. We're moving from being reactive to being proactive. It's about developing those solid professional habits that prevent problems before they even start.
Think of this as your mental checklist you run through every time you have an issue. It's your step-by-step algorithm right there at the chair. First, stop and make sure your holder is stable. Second, and look how high up this is, try a new tube. So often, it's just a faulty tube. Then, you classify the problem, correct it minimally, and you always abort for pain or swelling. Finally, you document what happened and pick a new site. It's a safe, repeatable process.
And speaking of documentation, when a draw doesn't go perfectly, you have to document it well. It's absolutely non-negotiable. This little mnemonic, SACD, helps you remember everything you need to write down: the site you used, the number of attempts, any changes or corrective actions you took, and the disposition, how the patient handled it and what the outcome was. This is crucial for patient care and for your own professional protection.
Honestly, if you remember just one thing from all of this, let it be this. Good preparation and a stable hand will beat fancy troubleshooting skills any day of the week. Taking that extra minute to really assess the vein, getting a good anchor, and keeping your hand steady, that's what solves 90% of these problems before they can even happen. That is the mark of a true pro.
So the next time you face a challenging draw, try to see it a little differently. Don't see it as a failure. See it as an opportunity. It's your chance to put all of these systematic professional habits into practice. It's how you turn a moment of potential error into a masterclass of skill, safety, and amazing patient care. It's how you show everyone, including yourself, what an expert you're becoming.